Good afternoon. Thank you for your kind introduction. It is a great honor to be invited to the International Congress of Acute Care Surgery today. My name is Seungwoo, and I am an assistant professor in the Department of Rehabilitation Medicine at Ulsan Medical Center. Today, I will be presenting on the topic of post-extubation dysphagia, specifically focusing on its assessment and various rehabilitation strategies. The presentation consists of two parts. First, I will conduct a comprehensive review of the existing literature regarding post-extubation dysphagia. Second, I will share the actual clinical protocols currently implemented in our hospital. First, I would like to clarify the terminology used in this field. The act of swallowing is referred to as yanha in Korean, and when this process is impaired, it is clinically defined as swallowing disorder, deglutition disorder, or commonly dysphagia. Swallowing serves two critical functions: the efficient transport of food from oral cavity into stomach, and the essential protection of the airway to ensure this process occurs safely. Interestingly, the English word swallow also refers to the bird, and a similar connection exists in the Chinese character for swallowing yan, which combines the radical for mouse gu and the bird swallow yan. It seems that ancient people across different cultures observed the wide gaping beak of a swallow and saw a profound symbolic connection to the human act of swallowing. Moving on to post-extubation dysphagia, it is defined as the inability to safely and effectively transfer food or liquids from the oral cavity to the GI tract, occurring either immediately after or at some time following endotracheal tube removal. The reported incidence ranges varies significantly depending on the diagnostic tools used and the timing of the assessment. Studies citing figures anywhere from 3% to as high as 83%. However, meta-analysis indicate that approximately 41% of critically ill patients experience this condition, and notably, asymptomatic aspiration occurs in about 36% of cases. This high rate of silent aspiration underscores a crucial clinical point. The mere absence of an overcough or choking does not necessarily mean that a patient is free of post-extubation dysphagia. According to the existing literature, patients with post-extubation dysphagia face significantly poorer clinical outcomes, including a threefold increase in 90-day mortality and a higher mortality rate that persists for up to 1 year. Furthermore, these patients tend to have longer stays in both the intensive care unit and the hospital overall. Key risk factors identified among critically patients including undergoing emergency intubation, requiring mechanical ventilation for more than 48 hours, being over the age of 65, and having a medical history of stroke or neuromuscular disorder. This figure outlines the clinical framework for understanding and managing post-extubation dysphagia. The pathomechanisms are multifactorial, involving global impairment of perception and disturbed sensory systems, direct laryngeal trauma, neuromuscular dysfunction, gastroesophageal reflux. Key risk factors that predispose patients to PED include baseline neurologic diseases, ICU emergency admission, prolonged invasive mechanical ventilation. To address these risks, step 1 assessment includes GUS ICU or Bernese ICU dysphagia algorithm, followed by step 2 confirmation through instrumental evaluation, such as fiber optic endoscopic evaluation of swallowing or video fluoroscopic swallowing study. Treatment strategies are divided into current standard care, including compensatory techniques, adaptive measure, rehabilitation, and other potential future interventions such as pharyngeal electrical stimulation, neurostimulation, and pharmacological interventions. According to the guidelines published in the Journal of Critical Care, managing dysphagia in the ICU requires a highly structured and evidence-based approach. As illustrated in figures, the process begins with ensuring the patient's respiratory readiness and mental alertness, a critical prerequisite for any swallowing assessment. For the tracheostomized group, the algorithm emphasized the importance of cough deflation tolerance and the use of one-way valves to restore subglottic pressure. In contrast, for the extubated group, we moved directly from bedside screening to more detailed clinical evaluations. In both pathways, if screening suggests a risk, the guidelines we strongly recommend instrumental assessment, particularly FIS, as a gold standard for bedside diagnosis in the ICU. The bottom section of these figures highlight the transition from compensatory techniques like postural adjustment to targeted rehabilitation interventions such as pharyngeal electrical stimulation. Next, I will discuss the specific swallowing rehabilitation protocols currently being implemented in our hospital. At our hospital, we operate a dedicated multidisciplinary team for patients admitted to the SICU, ensuring a holistic collaborative approach. This specialized team is composed of physiatrists, including myself, and alongside acute care surgeons, occupational therapists, and critical care nurses. The early rehabilitation protocol for mobility is already established and operating effectively. Under this system, dedicated nurses and physical therapists work together to provide one-on-one treatment. The six-stage protocol consisted of passive range of motion, active range of motion, sitting, standing, walking less than 10 meters, and walking more than 10 meters. The video on the left demonstrated stage 5, which involves the walking in place on a walking pad. You can see the dedicated nurses. And on the right figure illustrated stage 6, where the patient practices gait training with bodyweight support. To ensure the safe implementation of physical therapy, we strictly adhere to a comprehensive safety checklist. First, from a cardiovascular perspective, the use of vasopressor must be below the established cutoff, and the patient must maintain stable blood pressure and heart rate without a fever. Neurologically, we verify RAS score to ensure the appropriate level of consciousness and confirm that patient is capable of giving consent. Furthermore, we monitor respiratory parameters, including FiO2 and PEEP, as well as the respiratory rate and SpO2, to ensure they meet the predefined safety criteria before proceeding with the intervention. Initially, starting a swallowing rehabilitation algorithm felt quite overwhelming. To address this, our multidisciplinary team, including rehabilitation physiatrists, acute care surgeons, occupational therapists, nurses, gathered to exchange ideas and review existing literature. Our goal was to develop a practical swallowing rehabilitation algorithm. So this protocol was developed after the discussion. The protocol is divided into two main tracks, an ICU algorithm and step-down unit algorithm. In the ICU, we target patients who have undergone extubation or tracheostomy after requiring an artificial airway for more than 72 hours, 3 days. While the incidence of PED increases after 24 hours of intubation, we limited the criteria to 72 hours due to constraints in personnel and resources. The process begins with a formal referral to the Department of Rehabilitation Medicine, followed by a safety assessment conducted by ICU nurses, and a step using the same criteria as our physical therapy protocols. We then perform a risk assessment to check for conditions such as hyperactive gag reflex, gastroesophageal reflux, and foreign body sensation in the oral cavity, and gagging nausea after routine suctioning. Subsequently, RN staff and occupational therapists perform a clinical assessment using the GUS ICU as the gagging swallowing study as the primary screening tool. Patients score over 6 points proceed the direct testing, eating procedure, while those scoring 6 or below remain on indirect testing, indirect treatment without food. Follow-up clinical reassessments are conducted by occupational therapists and ICU nurses. Finally, the entire medical team collaborates to determine the appropriate diet level, and a new referral is made to rehabilitation medicine upon ICU discharge. The GOS ICU is repeated weekly or whenever there is a significant change in the patient's clinical status. Once the patient is transferred to the step-down unit, a formal rehabilitation consult is initiated to perform a thorough clinical reassessment, followed by a bedside flexible endoscopy evaluation of swallowing fees, which I perform personally. And based on this objective finding, we decide on interventions such as feeding tube removal or direct treatment or indirect treatment. The patient clinical progress is then continuously monitored and evaluated by occupational therapists and ICU nurses to ultimately determine the most appropriate and safe diet level for the patient. The primary bedside screening tool we utilize in the ICU is the GOS ICU, Gogging Swallow Screen for Intensive Care Unit, which consists of both indirect and direct tests, with a total score range from 0 to 10 points. The indirect test, worth a maximum of 6 points, requires a stable level of consciousness, specifically last 0 to +2, as well as the ability to perform a voluntary cough and successful saliva swallows without signs of drooling, stutter, or voice changes. However, it should be noted that a lack of detailed manuals can present limitation, especially for patients with tracheostomy tube. Once a patient successfully passes all criteria, we then perform a direct test with semi-solid, liquid, solid, and mixed textures. The patient is then evaluated for a final scores out of 10 based on the absence of swallowing delays, involuntary cough, drooling, or voice changes. This slide shows our multidisciplinary bedside screening during GOS ICU, and the process begins with an initial evaluation of oral function, specifically assessing tongue movement. Thereafter, a critical care nurse checks the patient hemodynamic stability. Once cleared, the nurse temporarily disconnects the ventilator and performs cough deballooning. After that, the therapist applied partial cannula plugging to facilitate airflow through the upper airway. This coordinated maneuver allows us to evaluate voice quality and cough strength using a tablet-based application. We objectively measure the vocal intensity and assess the patient's ability to generate a functional cough. To ensure patient safety and minimize respiratory distress, we prioritize procedure efficiency and quickly reconnecting the ventilator and performing endotracheal suctioning. Once the patient is transferred to the step-down unit, I personally perform a bedside fees using a portable flexible fiber optic endoscope to evaluate swallowing safety. By administering semi-solid and liquid consistency mixed with blue or green food coloring for enhanced contrast, we directly monitor for aspiration and bolus residue, as well as saliva pooling, vocal cord paralysis, or anatomical abnormalities. It is technically limited by the whiteout effect caused by pharyngeal constriction during the swallow, and maybe these fees may be contraindicated in cases of severe facial trauma. This slide demonstrates our targeted oral motor rehabilitation protocols. The video on the left shows an oral opening exercises where the patient is encouraged to maximize mouth opening. And on the right, the patient is performing a tongue protraction exercise, which focuses on strengthening of genioglossus muscle to enhance forward movement of the tongue. These exercises are essential for improving bolus control and oral transit efficiency. And next, on the left, we are performing tongue range of motion exercises, guiding the patients to move the tongue laterally to enhance bolus manipulation and oral transit. And on the right, the patient is engaged in the shakir exercise, utilizing resisted neck flexion to strengthen the suprahyoid muscle complex. This intervention is critical for improving laryngeal elevation and facilitating upper esophageal sphincter opening, thereby addressing pharyngeal phase impairments commonly observed in our ICU survivors. In addition to exercise shown in the videos, we implement several therapeutic maneuvers, such as Mendelssohn maneuver, which involves the maintaining laryngeal elevation for as long as possible to improve US opening, and the effortful swallow, where the patient is instructed to squeeze all their swallowing muscles as hard as they can. We also provide comprehensive education on compensatory techniques like the chin tuck position to protect the airway during ingestion and emphasize the critical importance of the oral hygiene. Furthermore, sensory stimulation remains a vital pillar of our rehabilitation framework. To ensure the safety and continuity of our ICU-based rehabilitation, we implemented a structural monitoring and documentation system, sorry for Korean, and this tracks recovery across physical, swallow, and cognitive domains. Following each session, we utilize a dedicated checklist to monitor vital signs, cough, choking response, and subjective symptoms. Specifically for dysphagia management, our individualized ICU rehab charts incorporate the GUS ICU score to address aspiration risk and the IDDSI, International Dysphagia Diet Standardization Initiative Framework, to precise, define, and communicate standardized diet levels for patients. This is a preliminary study comparing data from before and after the implementation of our ICU swallowing rehabilitation algorithm. This is not published yet. We compared the 35 patients and who received ICU-based swallowing rehabilitation with a historical cohort of 34 patients who had previously received traditional word-based rehabilitation. According to the ICU activity scale, the intervention group, more patients at stage 1 or 2, means that active or passive range of motion exercise only, meaning it encompasses a higher proportion of functionally badly ridden patients. While most demographic data show no significant differences, the ICU intervention group initiated rehabilitation approximately 5 days earlier compared to the control group, and with an average of 14 sessions, 5 sessions more than control group. As shown in table 2, which presents our main outcomes, the group that received the ICU intervention had a significantly higher rate of no or mild dysphagia upon instrumental evaluation. However, there was no significant difference between two groups in the ASA-NOM scale, which serve as a scale to measure the level of oral intake, where level 1 to 3 present patients who remain dependent on a feeding tube, and 4 through 7 indicate the patient is able to consume more than half of their nutrition requirement orally. This ICU swallowing rehabilitation protocol allowed us to provide intervention earlier and more frequently, leading to objectively confirmed improvements in swallowing function as measured by FIS or FSS. However, the level of actual oral intake did not show a significant difference between groups. This discrepancy likely suggests that the successful progression of oral feeding is not determined by swallowing function alone, but rather by a complex interplay of clinical factors, including medical stability, respiratory status, GI tolerance, and the patient's overall mental status. In conclusion, our preliminary findings suggest that a swallowing rehabilitation alone is insufficient to achieve a full oral intake. Rather, a multidisciplinary approach that addresses medical, respiratory, and nutrition stability is essential for successful recovery. However, this study is retrospective and small sample size and lacks long-term follow-up data to determine sustained outcomes. Thank you for your attention.